Hi, my name's Brittany Moore. I am presenting my week 6 SOAP note for FNP 597. I'm in Dr. Ashley Snook's class. So I'm doing my clinical rotation at the Camas and Colville Health Clinic in Camas, Utah. It's a rural family medicine clinic. The case that I chose was memorable and challenging at the same time. It was very sensitive nature dealing with domestic violence, and it was also very meaningful to me because the patient reached out to a provider at the clinic afterwards and expressed her gratitude for how compassionate I was in handling her case, and she appreciated that, and I appreciated that compliment. So for my case presentation on July 8th, I saw patient SL, 35-year-old non-Hispanic white female. She presented to the clinic unaccompanied with the chief complaint of, I'm having really bad anxiety and I can't sleep or eat. She has a past medical history of anxiety, depression, and ADHD. She appears to be a reliable historian. She reports that over the last 3 weeks, she has had worsening anxiety, insomnia, and decreased appetite. She said her anxiety is crippling. She's waking 4 to 5 times per night and eating less than 1 meal per day. She said the recent episode is due to running into her ex-husband at the grocery store 3 weeks ago. She said she divorced him 5 years ago and had to stay in a domestic violence shelter with her kids. She said she hasn't seen him in 3 years. She said that during the anxiety attack, she feels very worried. She has racing thoughts and she feels like she's in danger. They last from 10 minutes to hours and occur 3 to 4 times per day. She said the anxiety episodes that she feels cause her to feel chest pressure, hand tremors, heart palpitations, shortness of breath, nausea, and her skin gets flushed red. She said that triggers make her anxiety attacks worse. She said the triggers include seeing her ex-husband, going to the grocery store, the gas station, and then some smells. She tries to avoid those triggers. She reports experiencing a similar anxiety episodes in the past. She said she's been able to do some meditation to help, and that's usually worked. It's not working this time. She rates her anxiety at 9 to 10 out of 10 because of how much it's interfering with her daily life. She denies any suicidal ideations, plans, homicidal ideations, and doesn't have any auditory, visual, or tactile hallucinations. She's currently not taking any medications. She has no allergies. She's up to date on preventative care, has no surgical history or hospitalizations, has a Mirena IUD in place, and isn't sure when her last menstrual period was. Her mom has depression and her dad has hypertension. And then reviewing social history, she's divorced and has 2 children. For safety planning, I think it's important to note that her ex-husband is actually not the father of her children, and the father of the children is not involved in their life. She does work full-time and has a very strong family and friend support system. She doesn't use drugs, vape, tobacco, smoke. She said she drinks alcohol about 3 to 4 times per month. Her review of system is positive for fatigue, weight loss, heart palpitations, chest pressure, shortness of breath, nausea, flushed skin, headaches, hand tremors, anxiety, depression, and insomnia. Again, denies suicidal ideations, homicidal ideations, and hallucinations. Her vital signs are stable. She does have a low to normal BMI at 18.6. Her physical exam shows an appropriately dressed and developed thin adult female who is experiencing mild emotional distress. The rest of her exam is mostly unremarkable except for a mild tremor in her bilateral hands, and then that mild presentation of anxiety, tearfulness. She was crying throughout the visit, but she was able to maintain eye contact and had appropriate speech and an appropriate thought process. So given her presentation, I ordered a CBC, CMP, TSH with reflex, and a T4, reflex to T4, an EKG, and then had her fill out the GAD-7 and the PHQ-9. Her EKG was normal sinus rhythm, PHQ-9 was 20, which is severe depression, and the GAD-7 was 19, severe anxiety. So the differentials I considered were post-traumatic stress disorder, or PTSD, exacerbation of generalized anxiety disorder, given her history of anxiety, and hyperthyroidism. So to narrow down my differential diagnosis, I used the American Psychological Association Clinical Practice Guideline for PTSD. I used my preceptor, and then also reviewed information about the other differentials through scholarly websites and clinical practice guidelines. My critical thinking process involved identifying all of the potential causes of her symptoms. I wanted to make sure we're ruling out medical causes when handling mental health conditions, especially like hyperthyroidism, because it can cause anxiety, palpitations, and weight loss. Sorry, my contact. Um, so with her history of anxiety and depression and the scores on her PHQ-9 and GAD-7, considering an exacerbation of generalized anxiety disorder is reasonable. But despite her symptoms presenting as very similar to the expected presentation of generalized anxiety disorder, it wasn't my primary diagnosis because that diagnosis is typically not attributed to a physical cause, and her episodes are. So generalized anxiety disorder and post-traumatic stress disorder do have many overlapping symptoms, and the first line treatment actually is the same: SSRIs and therapy. They just have different therapy types. So treating one can usually help the other. So my primary diagnosis is PTSD because of her presentation and her history. So that history of that intimate partner violence, the intense psychological stress in response to triggers, avoidance of triggers, persistent fear and severe depression symptoms, and then hypervigilance and sleep disturbances. So I again use those clinical practice guidelines from the Veterans Affairs and the American Psychological Association. So for the plan, I ordered the labs to be drawn to rule out those medical causes, and then I had her complete the GAD-7 and the PHQ-9. That gave us baseline scores, and I'm going to have her complete those at every follow-up visit. I'll also have her complete the PCL-5, which is a self-rated measurement tool for PTSD symptoms. That can be repeated monthly or sooner if needed, according to the guideline. I started her on sertraline 25 milligrams once daily for a week. If she's tolerating that, I want her to bump up to 50 milligrams once daily for 3 weeks and then follow up. I also prescribed a low dose of hydroxyzine, so 25 milligrams every 6 hours as needed for anxiety symptoms. She said she's not used to taking medication, so I started her on a lower dose. The guidelines showed us start at 50 milligrams for anxiety, but given her just her saying she's not used to taking meds, I wanted to just start low and slow. The dose can be increased if needed. I also sent a referral to 2 psych mental health centers. They do sliding scales and free services for people who qualify. We discussed therapy. She said she can't afford it, so I still chose this treatment plan because it's based on the clinical practice guidelines. I also educated her about the side effects of the medications, and then we discussed a safety plan that included a domestic violence national hotline phone number and then the shelter phone number here locally. And then I stressed the importance of eating and staying hydrated and encouraged her to eat 3 small meals per day. I also encouraged her to journal and do some breath work as some non-pharmacologic measures, just so she can have some other tools in her toolbox since she's already practicing meditation. I explained that attending trauma-based therapy was really important, and I gave her the information for the offices as well as the reduced fee schedule. And then for follow-ups, I want to do a close follow-up with her in 2 weeks to look over medication effects, side effects, dosage, and then just go over her safety. I told her she can come back sooner if needed. She knows to call 911 for any imminent danger or any chest pain, difficulty breathing, confusion, or thoughts of harming herself or others. These plans are all supported by the clinical practice guidelines set forth by the treatment for PTSD by the U.S. Department of Veterans Affairs. I opted for the treatment plan because it includes therapy and medications, and this patient really needs assistance from an interdisciplinary team of providers to ensure that she can heal and has the appropriate resources to do so. Alternatives were different medications and maybe not even sending her to therapy because she said she can't afford it, but that's not the best patient-centered care, so we opted not to do that. For a holistic approach, I collaborated with my preceptor and other healthcare providers by sending referrals, and then through shared decision making, I included the patient in all of this diagnosis and planning. I wanted her to feel empowered. And then when considering Jean Watson's Kurgatus processes, I really considered 4, 5, and 8. Building a strong, caring relationship, that was really essential for helping her feel safe to discuss her trauma, allowing her to express her emotions, positive and negative, through authentic listening, and then also creating a healing environment. So I tried to be calm and be supportive and strong for her so she could feel safe and heard and respected and empowered so she could participate in this. I think I did a good job because she called the clinic and said I was compassionate and great, and that really supports me using those Gene Watson Caritas processes. So overall, this was a case I haven't dealt with in my rotations, but I'm really grateful that I had the opportunity to deal with it.